So what do you,
Okay, welcome everyone. It's so nice to see everybody back for our fourth webinar of the summer series. And so we're excited that you're here today. So my name, if anybody doesn't know, I'm Lee. I'm the manager of Rondo Seminars, and I've been working with Dr. Rondo and Rondo Seminars for 21 years. Now, today we have Bill Van Evans of Orthodont and ATFC, and he will be speaking on functional appliances, and we're very excited to have him share that with us. So this is the fourth webinar we have over the course of the summer, and upcoming we'll have a few more. Next one is best case finishing tips with Dr. Mike Lowry. Then we have Froggy Mouth and AMCOP appliance with Gori Cotinini. And the final one will be utilizing bite turbos in orthodontic treatment with Dr. Mike Sepernek. So all of these registered, all of you are registered today, will be automatically added to the remaining webinar series. There's plenty of room. Tell all your friends. We can share it with anybody you'd like. So a little bit about this platform. So feel free to use the chat. And Bill had mentioned that he will be going through multiple appliances. If you had a specific question on the appliance that was on the screen, just write it in the chat and I will make sure to address it with everybody. So make sure you use that. You can also reach out to me. I'll keep my eye on my email. It's lee@rondoseminars.com. And if you have technical issues as well, I'll help the best I can. So now a little bit about Bill. So please join me in welcoming Bill Van Evans. He's the founder of Orthodont Labs over 40 years ago and has been a valued part of Rondo Seminars for nearly as long. As president of Orthodont based in Oshawa, Ontario, he leads the company's operations and sets its strategic direction. He's a graduate of York University with a degree in business and marketing, and he also prioritizes staying ahead of the curve. Since graduation, Bill has become a registered dental technician in Ontario, completed a Master's of Science in Oral Health, and a PhD in Integrative Medicine. He's especially passionate about new technologies and most recently the AMCOP appliance. We're thrilled to have him here tonight to share his expertise on functional appliances. Take it away, Bill.
Thank you, Lee, and welcome everyone. It's great to see you all here. And what I wanted to do tonight was to go through a number of different appliances that we make and certainly that Brock uses. And these are the most common that we see in our practice. However, they're by far not the complete list. We've got different appliances, whether they're fixed or removable, or fixed for the patient, removable for the doctor, that can accomplish just about any movement you're looking to do. And functional appliances are meant to not necessarily, but sometimes correct a tooth position, but more importantly, to correct a jaw relationship problem or a jaw size problem. So, and what I'd like to do is go through them fixed first, and then removable, and then because we've got, Lee mentioned Gori Cotinini going to speak on the AMCOP and Froggy Mouth appliances. I'll spend about 30 seconds on each of those, and Gori will go into those much deeper. But they're new on the scene in North America. These appliances have been used in Europe for quite a few years and have got tremendous following there. And we're seeing a number of practitioners in North America are being very adoptive to these appliances for use in their practice and in helping their patients. And then Lee had also mentioned that she'd had some requests from some that had signed up to do something on appliance adjustments. So we'll try and do that towards the end. So let's get started. So the first appliances that I've got here, these are part of the Series 2000 family of appliances. And the Series 2000 family of appliances were developed by an orthodontist out of Gulfport, Mississippi by the name of Mike Williams. Leading into the year 2000. And like everything at that time, everybody was concerned that all of our computers were going to crash. The world was hopefully not going to end, but we needed to do something to get ready for the new millennium and get ready for a new world we were going to live in. So what Michael found with his patients and his practice was that he wanted fixed appliances because he had patients that came from all over. Their hygiene wasn't good. They lost things. So fixed was the way to go for him. And he also wanted appliances that were really self-adjusting, because he also found that the kids and the parents were not necessarily the greatest cooperators. They didn't follow his instructions. They would lose things. So he wanted fixed appliances that were self-adjusting. So what he developed is a whole family of appliances that are self-activating using nickel titanium coil spring. And what's interesting about these is that as the spring expresses itself, it's a consistent force for an extremely long lifetime of that spring. So it's the fancy name is the hysteresis curve of that spring, is that it doesn't matter how much you compress it or how stretched it is, the force level is still the same. So when we make these appliances, we want to make them active for the longest possible period, and then it's easy for you to stop the activation when you're ready. You just simply place some flowable composite over the exposed spring. So if you look on the appliance to the far left on your screen, that is called an MSX, and that simply stands for mandibular spring expander. So you can see that there's one piece of coil spring. Lee, does my cursor show up on the screen?
Yes, it does.
It does, okay. So
Yep.
if you look over in this quadrant, there's coil spring here, and the effect of this coil is to widen the arch symmetrically. This is not part on the right, part on the left appliance. It's bilateral expansion. And then here is also open coil, and also right here. Now these coils are pretty much fully compressed. So as long as you can see that that spring is not fully open, and on this one, you can see that the distance between the pitch of the coils, that's the pitch. As long as it's not open like this, that spring is still active. So these springs are compressed, and when we send the appliance to you, they're held together with stainless steel ligature ties. So that's what's right here and right across here. These appliances are not meant to be worn like that. They're there so that you can actually cement them in the mouth. So when it comes to you on the model, the appliance is passive, but it's held that way by that ligature wire. So when you cement it, you want to always cement the smallest bands first with these appliances. So in this case, it would mean cementing the first bicuspids and then seating the bands on the molars and cementing those. So it's in a, it's done at the same time. So it's one mix of material, or if you're taking it out of a syringe that's light cured, do it all at once. And then when you insert it, smallest bands first, and then the larger molar bands. Then once the cement is cured, you cut and remove the wire ligature tie and the appliance is active. You just simply then send the patient away and they're on their way. And when they come back, you'll expect in the first month to see this because it's very light force, very continuous, gentle force spring. Quite possibly nothing happens in the first month. And don't think the appliance isn't working. This is what we routinely see. And then after the first month, we see development at the rate of about 1 millimeter per month. Now, these springs are all 150 grams of force, unless you specifically ask us to do otherwise. But Mike Williams found out that this was a good force level to use consistently. On this upper here, there are two spring modules, one here and one here. They're both 150 grams each, so effectively we've got 300 grams of force across the midline to develop this arch. In the posterior segments, we've got spring here and here. And in the design of this appliance is to widen the arch and distalize the molar. So this is what's called a DMAX 2000. DMAX simply stands for distalizing maxillary expander. On the right-hand side, we've got the deciduous version of the SAG 2000. So we've got, again, two drive mechanisms here and here, and a midline screw. And the midline screw here is as much to hold the three pieces together as it is to try and expand this arch. This is more about creating arch length than creating arch width. And on the deciduous version, we band the deciduous cuspids and the molars, not the permanent molars. In the permanent dentition appliance, we band the first bicuspids, first molars, and then we actually lute the acrylic in place on the anteriors. And anyone who's interested in more information on the Series 2000 appliances, if you go to our website or if you send me an email, we'll make sure that we send you the full brochure on those appliances. This one is called an expider. And if you notice here, there's a threaded screw mechanism here. And at the back here is a hinge. So when you turn this appliance, again, it's fixed, it expands in the cuspid and bicuspid area bilaterally with no expansion in the molar width. So if you had a patient that had a normal sized molar width, so somewhere 38 millimeters across the lingual at the gingival margin, but a narrow cuspid to cuspid area that you wanted to widen without widening the molar, then this is a great appliance choice because that's all that this does, just widens the anterior section. This is a lower transforce transverse appliance. So again, self-activating. Internal here is nickel titanium coil spring. And when you put this appliance in, it's going to expand about 4 millimeters. And if you want to stop this appliance, you take a pair of 3-prong pliers and just simply crimp this at the drive mechanism here. What's nice about this is we can incorporate lap springs over the incisors so that as we broaden this lower arch and upright these teeth, you can activate the lap springs to push these laterals forward and start to round out the arch form. The other thing you'll notice about this appliance is that it's removable on lingual sheaths. So I've mentioned that we can expand about 4 millimeters with this type of appliance. If you needed a whole lot more than that, you're probably going to want to use a couple of these modules. And by making this on lingual sheaths on bands, this appliance could be removed and the next one in the series could be placed in the same lingual sheath on the same molar band. So it saves you from having to refit bands. This is the same appliance in an upper version and does exactly the same thing, same lap springs. And it just, these are nice, simple appliances, especially to be used in mixed dentition children, because it opens up a lot of tongue space. So it helps the patient to breathe, and it helps them to create a proper tongue posture. So there are a fair number of advantages to these types of appliances. This one is kind of interesting because this is a combination. You can see the screw on the midline to develop the midline, but then also we've got active coil spring here to distalize this molar. And typically to make this work, we're going to have a rest or a band on this bicuspid because we need anchorage to move this molar back, particularly if there's a second molar in place, because we don't want the appliance to simply slide forward. We want the anchorage to be in place, and we want the tooth that we want to move to be the active moving teeth. And typically when we're designing an appliance, we want to consider that we want 2/3 of the arch to be the anchorage component and 1/3 as the movement component. So it does become very important that we've got good anchorage here. So the way this is sitting right now, this tooth has been moved back, we've cut the anchorage free, and we're still expanding on the midline. Otherwise, you would see, as I said, either a band or a bondable rest on this bicuspid. This is another version of a fixed fan appliance by having a helical loop or an omega loop at the back of the palate. When you turn the screw in the front, we're going to widen through the cuspid bicuspid area. We've extended springs to make sure that the laterals get broadened out here as well. But if you wanted some expansion in the molar region or even contraction, you can control that by adjusting that omega loop in this appliance. So this one has some advantages over the expider. It's also a little bit physically smaller, so it does increase some tongue space for the patient. This is one of Brock's favorite appliances. On the right side of the screen, this is the traditional Rickinator. Nice small little ramp in the anterior, and the ramp can either be flat if we're not looking to advance the lower jaw at all, and we just want to increase vertical. If we incorporate a ramp, we can advance the lower jaw up to about 4 millimeters. On the left side, you'll see an expansion version. So we take a little small half Hyrax or mini screw and put it across the molar bands, turn that screw. We do cut the Rickinator itself in half so that the right and left side operate independently. but it'll perform the same function as the ramp on the appliance to either just increase vertical or increase vertical and advance the lower jaw, but expand if we're a little bit short of width. These components, this is called a fixed jet appliance, and jet is simply the component right here, or here, and here. So on the left side, this is simply an expansion appliance. It's going to increase the molar bicuspid width of the patient's arch, and we can either have bands or rests on the first bicuspids, but we do want good anchorage. And this again is an appliance that we can control the amount of spring that we use, and we can control the number of components we use. So this spring comes anywhere from 120 grams of force to 280 grams of force. And if we had 2 units, that would double the 280, and that would give us 560 grams of force if you wanted that much. And typically we are using around 200 grams of force in these. So if you want to use one of these appliances and you want to talk to us about changing the force levels of the spring, just let us know. On the on the right side, this is a distal jet version of this appliance. And the way we activate these, it's all the same. When we make the appliance, we give you a little Allen key that fits in this little hex screw. You undo it, and then you slide this component in the direction of the spring to compress the spring. So to distalize, we're going to slide the spring this way. To increase the width, we're going to slide this way and compress the pitch of this spring. And then you simply tighten the screw down again. Now, what's nice about this is when you've got the expansion that you're looking for, the movement that you're looking for, you would just undo the set screw again and slide it so that the spring is now passive, and then tighten it down, and that becomes your retainer. So in this one, we would, we would compress the spring, move the molar back, and then when you've got the molar moved back as far as you want, because we're trying to make room for the cuspid here, relax it, tighten it down. And then the other thing that's good here is that in this in this appliance, once you've got this tightened down, you would just simply take our high speed, cut the wire here and here, and then remove the bands, and now you've instantly got a Nance. You don't need to send it back to the lab for modification or have another appliance made. This converts right into a Nance appliance. So for straight molar distalization, this appliance has some advantages over the Series 2000 style. This is another one of Brock's big appliances that he loves to use for functional correction for class 3s. This is a fixed tandem appliance, which is really meant for deficient maxillas when we're trying to pull the maxillary arch forward. And we connect during the nighttime an elastic from here to here. And we do that on both sides. And the idea there is we've got a heavy pull elastic. It's an orthopedic pull, not an orthodontic pull. So it's 16 ounces of elastic force going from here to here and here to here. And we want to adjust this so that when it's in the mouth, there's about a 30-degree downward moment to hook up to this, because that's how the sutures in the head are. And we want to slide this whole maxillary arch forward. In the daytime, we don't ever ask the patient to wear this face bow when they're out of the house. So when they're at school or when they're playing sports or outside, face bow comes out, and the patient then wears a regular class 3 elastic from the hook on the molar band. And there's a hook, on this particular model, there's a hook on the cuspid here. So during the day, regular class 3 elastics, orthodontic pull, and at night, orthopedic pull from here to here. When we first started making this appliance years ago, we didn't have the daytime elastics. The patient wore the heavy pull elastics in the night, and nothing in the day. What we found was that during the day, if we had no traction, there was the opportunity for some relapse. So by having the appliance wear day and night, we get much more effective wear. So this is the same appliance, but shown from the occlusal version. The upper is always fixed. This is a fixed lower, and we can either band the bicuspids or the cuspids, and this face bow slides in and out of headgear tubes on the lower molar bands. So fairly unobtrusive appliance, but very, very effective. This is the same appliance, but in a removable version. And again, the upper is fixed. The lower is a conventional orthotic with a relatively flat occlusal table so that we can have the arches sliding. And you may ask the question, why would I want a removable lower? Some patients, when we put on class 3 elastics, we're effectively using the mandible as the anchorage and trying to drive the mandible back. So if they had some TMJ trouble and we put an orthotic in to help separate and create superior joint space, this would help those patients. So if you put in a conventional tandem or class 3 elastics and the patient was in pain, then this would be a good option because it would give you some increased vertical and help that patient. So same appliance, and you can see this is just a removable. Same idea. We've got the hooks here in the cuspid area for the elastics in the daytime, and this whole face bow arrangement gets taken out during the day and worn at night. The thing we're finding most often with these appliances lately is that a lot of the upper component now, rather than being a Hyrax, is a fixed three-way sagittal, and I will show that appliance later. The other thing we find is that even if you don't need to expand the maxilla, you should. Even if it comes to the point of opening the screw and then turning it back. And the idea behind that is to just wake up the maxillary arch and let it know that something's going to go on and we're expecting some movement and some change. And you're creating a little bit of trauma that creates this increased osteoblastic and osteoclastic activity that helps to accelerate this process. This is an ALF appliance, and this happens to be a pediatric version of the appliance. So ALF is Advanced Lightwire Functional. These are tremendously powerful appliances that will help young developing patients and adults. If you look at a patient that has a bunch of asymmetry, and that's quite often easily noticed if you look at the eyes and the ear position. One ear might be turned out considerably more than the other. One eye might be higher and larger than the other. These are patients, or also the other thing we would notice as dental practitioners is that they've got a very strong cant to the maxillary plane. That's because there's some cranial distortion somewhere. Well, these appliances are tremendous at fixing those because we can make three-dimensional adjustments to help these patients and get them back into balance. This is another Series 2000 appliance. This one is simply midline. And I know you can't see it because of the dark acrylic here, but there's a drive component here, and you can see a little bit of one right here. So again, 300 grams of force right across the midline. No anterior or distal movement here in this appliance. This is another fixed appliance. This one is set up to distalize the molar, and this uses a different component. It's called an Inman component. The active component is right here. And if you look, you can see these little wedge-shaped locks. When you push this way, it compresses the spring. You cannot push it back. It locks. It only goes one way. So again, we can, we're anchoring against the bicuspids and a large part of the palate to, in this case, distalize molars. Now we can make this same appliance if we want to push the anterior forward, or if we want to set it up as a posterior sagittal. You just need to let us know which kind of design you're looking for. And again, once you had your molars moved, or you'd move the anterior forward, you can take your high speed, cut this right here, and then you've instantly got a nance that you would leave in the mouth for anchorage. This is called a GR expander. GR stands for Herman Ramirez. Herman is a pediatric dentist, and Herman's thought is always about maximum space for the tongue. because he wants the patient to have as large an airway as we can. We want to give the tongue room to be placed in the proper spot and to have the proper function. So if you look at this, and all of our fixed screws that we do have markings on them, this is an arrow to show you which direction you're going to turn this little screw. So that means that the key goes in from the front of the mouth, you put it in, and then you push it down towards the back of the throat. When it releases, that's one turn of the screw, 1/4 of a millimeter of expansion, and then it's ready for the next insertion. And what's nice about this screw, instead of the regular high rack screw, it's only got one sliding guide pin and one threaded spindle. So it makes the screw almost half the size of a normal high rack screw. So we use this where size is a concern and in lower arches to get a fixed expander like this. The other thing I'd point out to you here is the number 12. The significance of that is that this screw has 12 millimeters of expansion built in before the screw will come apart. And the reason I say come apart is if you turn that screw 13 millimeters, you would have a right side and a left side in your hand. The screws are assembled, and when you turn the spindle, you're effectively unwinding the threaded screw mechanism that has been wound in. So yes, if you turn the screw too far, they will come apart, whether that's a fixed one or a removable. And yes, it would also be easy to make the screws so that they couldn't come apart, but it would make them physically bigger. So there's a trade-off there, but it's nice that we know how much expansions we can create. And the screws come different sizes. They come anywhere from seven, and they're even in odd numbers. So anywhere from 7 to 13 millimeters of expansion built into a regular screw. And then we do have some telescopic screws that even have more. So depending on how much room we're trying to create for the patient, we do select a screw that seems appropriate for that. This one is a D-Max RPE. So again, you see the arrows showing the direction of the screw. You see the 8. So that tells us this is an 8 millimeter screw. And then you see the coil spring here to distalize the molar. So this is what I was talking about. This is probably a better example. You can see how tight the coils of the spring are on this side and how much more open they are on this side. And again, this is just a sample model. So they're not necessarily indicative of the right appliance on the particular dentition of the sample, but you can see the difference in the springs here. And we try and pack in as much spring as we possibly can. This one is an MSC. So again, open coil, and a screw. So one of the first ones I showed was an MSX, mandibular spring expander. Mandibular MSC is a mandibular screw expander. And the easy question to ask is, why would you use a screw instead of a spring? And the answer to that is that if you only wanted maybe 2 or 3 millimeters of expansion, it's easier to control that with a screw than it is a spring. As I'd mentioned that initially in the first month, we get quite often 0 arch development, and then it's a millimeter a month. So if your patient disappeared on you, you might get more expansion than you wanted if it was a small amount. With a screw, you just simply stop turning the screw and you've got better control over that. But if you're looking for greater amounts of arch movement, then definitely the spring is the better way to go. Small amounts, the screw. Now this is something that's new for us. And I know that in Brock's office, they've been using a lot of these. Everybody's excited about 3D printing these days. So what we've been doing for a while, and we started by 3D printing frameworks for partial dentures. Well, the same machine, we can print effectively a band. And what's nice about that is that the bands that we're printing are thicker and stronger because the material is chrome cobalt, it's Vitalium. So it's a little bit stiffer. It doesn't have the same flexibility as a band, but it doesn't And because it's stiffer and stronger, we don't need it to pass through the contacts. The band itself is much shorter, and it only fits on the tooth as to what's visible from either an impression or an intraoral scan. And it's strong enough to withhold the the strength that we need for the appliance without going through that contact. So what that really does for you is it saves you an appointment. Patient comes in for the scan, you send us the scan to make the appliance, it comes back to you in a week, you put it in. There is no separation, and a lot of patients will tell you the most painful thing through the entire treatment process of orthodontics is the separators. So if we can, number one, eliminate that pain for the patient, and number two, eliminate a separation of band fitting appointment for you, I think that's a great thing. The other thing I'd like to point out to you is this one shows a number here, 900. That's the force level of this leaf spring. And these screws come in either 900 or 450 grams of force. So if you think about the traditional rapid palatal expander, that's where we'd want to use the 900-gram coil or leaf spring expander to create that. If you want what we think of more as normal slow palatal expansion now, we want to use the 450-gram spring. And if you look here, you'll also see this is a number 6. So this one has 6 millimeters of expansion. The other thing I'd point out to you is this little piece of string, and this is a little clip. So when the appliance comes to you, it comes to you like this. It's passive. You cement it. Once the appliance is cemented, you pull on the string. That will remove the clip, and these little leaf springs in here will be instantly active in exerting, in this case, 900 grams of force to broaden out this arch. I'm going to try and let me Lee, is there an easy way for me to get back to my camera at this point?
So the best way to do that is to stop sharing.
Okay.
There.
So can everybody see me now? And see the appliance?
I can see it. Yep. Hold it steady there because it gets a little wonky when you get too close. There you go. Okay.
Okay. So this is the way the appliance comes to you, just as I had in that picture. You cement it. And then, so I'm going to have to hold it because this appliance is removable from the model. But you pull on the string. The clip comes off just like that. Now watch what happens when I take the appliance off the model.
Hold it up.
See how that spring has now expressed itself, and this side, the appliance is now that 6 millimeters wider than it was when it was in the passive state. And if you look closely, you can see that the leaves in the spring have expressed themselves. So I can now, if I want, I can compress it back to that original state, but that's what the appliance is doing. So what's nice about these is that if you had a patient who was some patients, unfortunately, the parents are split up. Whatever they've got going on, they spend some time with the mother, some time with the father. Nobody then has to worry about turning the key or turning the screw for that patient. It's all automatic. The other place that these have tremendous application is we're seeing a lot of adults in treatment today that are 20 or 30 years old that are living on their own. If you give them a high rack screw or an I3E screw to turn on their own, it's extremely difficult. If we can give them something that is self-activating, that nobody has to be concerned about, then it's far, far easier for that treatment to be successful. Why am I not? Okay, we've done. DMAX we talked about, Series 2000 again, active coil, distalizing. When we're finished and we need to hold, and Brock will tell you, when you've expanded, distalized, created an expressive movement, We always need to hold for 6 months so that we don't have relapse. And one of the easiest ways to do that if we're moving into fixed braces is to use a Nance. And if that's the case, we would have molar tubes so that we can get into our active straight wire and use that at the same time as this appliance. The other appliance that I'd mentioned was a fixed three-way sagittal. So this is what we call a fixed barrel. And most of the tandems that we make today use this as the upper component. So this one has 3 screws, one on the midline to create midline development, and then 2 in the posterior segments to create arch length. So I'd mentioned that we like to have 2/3 of the arch as anchorage, 1/3 as movement. By having this rest on the bicuspid or a band, tying it to the molar, the 2 posterior segments become the anchor segment. And when you turn these screws together, the anterior segment goes forward. So we can make this appliance to be a posterior sagittal type or an anterior sagittal. And then if typically we're going to turn the posterior side screws first to correct the arch length problem, and then turn the midline screw after, because when you look at this picture, you can see that the posterior screws are in a little bit of a V shape. So when we create arch length, we also do create some arch width. And if you did the midline first, you might end up with more width than you really wanted or needed. The only exception as to where we would do midline first would be a class 2 division 2 case, because we would need to create some room first to allow the centrals to come forward. Now, that's the bulk of the fixed appliances. This is probably one of Brock's favorite little appliances to use in young patients where they come in where they've got arch deficiencies. Upper removable Schwarz. This one has pads. Pads do a couple of things. They help to cancel out the occlusion of erupting teeth when you're in the mixed dentition. They also help to give a chewing surface. Brock does like to use 4 clasps on these appliances. So we've got clasps on the molars, and deciduous premolars or first bicuspids. The downside to a pad is it is increased bulk in the mouth, and you can also accomplish the same thing by doing direct buildups in the mouth if you've got, if you're looking to control vertical that way. The pads are good if you've got a vertical grower, and if the patient is a short face, we don't want the pads because we want the posterior teeth to erupt. So again, it's, the thought is about what design are we looking to create, and why would we want one versus the other? Similar appliance. This one we've put a labial bow on. And what's interesting here is we've got a midline screw. And as you can see with these screws, there's always a little arrow. There's a little arrow visible from the intaglio surface and the polished outside surface so that the patient can see the direction to turn the screw. So this screw would push this lateral forward once you've created room for it. There's no point in trying to adjust this screw and push that tooth until we've already opened up some space here, because there's no place for that tooth to go. We used to do these appliances with finger springs. A lot of our customers don't like bending wire and adjusting springs, so we find the screws much easier. So we do make quite a few of these. And if you've got, a couple of teeth or 1 tooth, 2 teeth, whatever it is in crossbite, then this is a great way, very simple, easy way to fix that for these young kids. This is an anterior removable sagittal. So again, the 2/3 anchorage component idea. So the right and left posterior sides, you turn these two screws together, and this middle piece comes forward to open up space. So what I'm trying to show through these slides is we've got fixed and removable options to really create the same type of movement. So you can pick, whether your patient you think would be a good candidate for a removable or a better candidate for fixed. This one, if you look here, the screws are cut right mesial to the first molar on both sides. So again, this is not a good example based on this model, but if you wanted to move the posterior segments back, like we showed in the D-Max or in the lower Series 2000 appliance, this is the removable way to do that. This is again an upper Anterior sagittal, this time no pads. So this would be one where if you wanted an anterior bite plane to help open the bite and make the appliance a little bit smaller, would be a good appliance to use for the patient. This is an interesting one. This is called an Inman aligner. When this appliance is off the model, there's spring here and here that is retractive to pull this labial bow back, and there's also spring here and here. And this little insert piece here is trying to push forward. So this appliance works just like aligners would, Invisalign or Spark or our Streamline aligners, any one of those, to align the centrals and laterals, whether it's the upper arch or the lower arch. It only works on centrals and laterals, and it does a beautiful job of rotating and putting the teeth into nice alignment. The beauty of this appliance is it's one appliance and it's done. This serves as the patient's permanent retainer, unless you're going to put in a fixed one, but they only buy one appliance, so the whole cost of this treatment from a lab fee standpoint is under $200. This is the famous twin block, upper and lower appliances with a pad on each that fit together at a 70-degree angle. And the idea is for a class 2 deep bite patient. We want to bring the lower jaw forward, and that's what the block does. And then in this case, because it's a deep bite, we want to trim this acrylic away to let these teeth erupt. So this is a twofold appliance. There it is independently. And the question that we get asked all the time is, how do I know how much acrylic to take away to let those teeth erupt? And what we tell people is take a Sharpie, a black Sharpie, and just color in this pad section on the appliance. And then take a straight handpiece with an acrylic burr and remove the black. And what you're trying to do is create about 1 millimeter of space. Don't put any of that, of the black here on the front of the wedge. You want to leave that intact, and you only want to create a little bit of space each time the patient comes in. The reason we don't want to remove all the acrylic at once is that if you do, you're going to develop a lateral tongue thrust. The tongue will find that space, but if it's only 1 millimeter, it won't be a problem for the patient. Again, we talked about a Nance appliance to retain after expansion. Well, if you've expanded an appliance, you need to do something to hold that. You can't just do a fixed lateral to lateral or cuspid to cuspid retainer. We want to do something to help maintain the upper molar width. So these are just a couple of upper retainers. Most of the retainers that we do now, instead of using a wire for a labial bow, we use something called a clear bow. So it's an aesthetic retainer. It's perfectly clear. It's made of polycarbonate material. It's very strong, so we can incorporate designs in the appliance for the patients because they do get pretty excited about that. But when you look at it from the front, it's nice and clear. This is an appliance that is specifically made to upright lower posterior segments. It's called a bow beer. And if you look down occlusally at the patient and you only saw teeth on the lingual and no tissue, that means that the teeth are tipped lingually and we need to upright them. This is an appliance specifically designed to do that. You just simply keep tightening the screw to keep it tight. And as the teeth upright, you'll need to tighten the screw again. And typically this is worn in conjunction with straight wire. This is a fixed alternative to the twin block, and we wear this in adult patients. We want to make sure that the roots are fully formed on the permanent first molars, and typically we want to wait until after age 11 that the second molars are erupted, because then we're pretty sure that we've got good, stable, solid roots on the first permanent molar. So this is not really a mixed dentition appliance. If you need something fixed in the mixed dentition, we will do something different. And on this example, you can see there's a transpalatal arch on the upper. I think the more common version of this appliance has an expansion screw there, because most class 2s, and the same thing with the twin block, probably 85 or 90% of them, we're putting an expansion screw in the upper component. This is what it looks like from the side. This shield is to help comfort the soft tissue on the cheek so that it doesn't, this piece here is called the elbow, and this piece is called the cam. And the cam, if we go back, if you look at this cam, it sticks out towards the cheek. So if we put this shield on the side, it makes it much more comfortable for the patient. What you're seeing here is a shim. This one is 2 millimeters long. So if we remove this little separating donut, we can slide the elbow out, and we can advance these 1 or 2 or 3 or 4 millimeters at a time as we want to step the mandible forward to complete treatment. Transpalatal arch just for anchorage. Now, Lee did mention AMCOP and froggy mouth. So AMCOP is a myofunctional device. It looks like a positioner, or if you like, an upper and lower mouth guard. They're elastodontic products that are very, very comfortable for the patients to wear, and the protocol for wearing is actually quite short. What's different about these appliances from other competitive products like MyoMunchie or MyoBrace is that we're typically using one only and sometimes 2 appliances to go through treatment rather than going through 3 or 4 different appliances. So the cost to the patient and the number of visits to the practitioner are greatly reduced. And the other thing that's nice about these is the material itself is different than everybody else's material. So you can actually modify this material. If you take the appliance and you put it in a bath of hot water, and you then with your fingers expand the appliance. So you're changing the arch form, you're just broadening the arch form out, and then you put it in ice water and cool it back down, it will take on that new set. It will now become a physically bigger appliance. So as your patient adapts and remodels, you can modify the appliance to use it as an expansion appliance. If, again, at the end of this presentation, I'll give you my email address. There's full scientific material available on the AMCOP and the froggy mouth device. So we can send you that information, or we get you the QR code just to scan, and you can get that all yourself. But very, very easy protocol to follow, minimal appliances to choose from. And certainly when you're starting to prescribe these appliances, if you give us some information about your patient, then we can help you select the appropriate appliance for that patient. We don't charge for that service. In fact, the medical director of Mycerium, Dr. Filippo Cardarelli, will get involved in treatment planning and appliance selection for you. What he wants to do that is simply copy the patient's CEF and records, and he'll help work you through that. Certainly a better solution is to take a course through Rondo seminars, because then you will learn the protocol, you'll learn the appliance selection and the case diagnosis, and then pick your own. And if you have these in your inventory in your office, it's actually a very, very minimal inventory to stock. The other one is froggy mouth, which was developed by an orthodontist out of France by the name of Patrick Filous. And what froggy mouth does is help to retrain an aberrant tongue swallow. So when patients should be evolving into the adult swallow pattern and don't, we've got mouth breathing, open lip posture, tongue thrusting. What the froggy mouth does is it simply rests between the lips, keeps the lips apart, changes the proprioception and the way the brain thinks about having to swallow. And this is very interesting because the patient wears this for 15 minutes, either once or twice a day, while they're sitting straight up. And the easy way to get them to do that is to have them sit in a chair or on the couch and watch TV. We want them looking straight ahead. So if it means changing the height of the TV or changing the height of where they're sitting, we have to do that. We want the back upright, not touching anything. But these can be life-changing, because if you've got a patient that's breathing through the air, through their mouth, developing all kinds of allergy problems, ear problems, not sleeping properly, stunted growth, ADHD, all these issues, something this simple can turn that around for them. And for this appliance, there truly are only 3 sizes. And the way you determine the size is just measure from corner to corner the lips. So we're just looking for the commissure of the lips, and that's it. Small, medium, and large sizes. Most adolescents, young mixed dentition kids are going to be smalls. Adults and teenage patients typically would be mediums. The large represents probably less than 10% of the population. So it would be, patients, when you visually look at them, have large mouths, wide lips. So very, very simple protocol to instill in your practice. And this is, the studies show this to be true, that 60% of these children retain the juvenile tongue swallow and need help. So if you see patients in your practice, and there's going to be lots of them, that after age 6, 7, if that tongue swallow pattern is not correct, we want to give them some help. Very, very inexpensive, very cost-effective, simple treatment. This is the easy way to get a hold of me. And as I say, if anyone would like copies of these pictures, let me know. And if you would like more information on froggy mouth and AMCOP, Lee has an upcoming webinar with Gory, and he will do a great job of explaining those to you. Any appliance questions that you have, we're always happy to help with designs for cases. I'm certainly available to help you with consultations anytime through phone or email. And I do have a quick presentation on appliance designs. Lee, do we have any questions from the group?
Actually, yes, I'd learned a lot there. Thank you. Yeah, I do. So I just have a couple of questions here, which are really good. So now there's fixed and there's removable. So which one is actually better?
So that sounds like a real simple question. And the answer is it depends on really, number one, if the patient's not going to cooperate with removable, then the answer is easy. Removable is out, fixed is in. If you had a patient that was played a reed instrument, then typically removable is going to be better for that patient, because those are the most difficult instruments to play when you've got something that's foreign in the mouth. When we put an appliance in, it always takes a couple of days to adjust. So you'll notice when you give an appliance to your patient, they speak differently. They're salivating more. Typically that goes away in a couple of days, with the exception of something like a ricinator, where we've got a bulk of acrylic right where we want the tongue to go to properly enunciate sound. So it depends what we're really trying to accomplish. The other thing is that sometimes removable is better just because patients we're trying to treat are in the mixed dentition. And some of the teeth we would want as anchorage units are going to be exfoliating, and new ones are going to come in. So those are all considerations when we're trying to pick fixed or removable.
Okay, perfect. Thank you. I do have another question here. So I saw there's a labial bow on some of those. When would you use that, and when would you not have a labial bow? Do they all come with labial bows, the removables, the Schwarz and stuff?
For us from the lab, it's good to put them on everything because we get paid for that. But typically, no. We put them on if there's a use for it. So if you had flared teeth and we were looking to develop the arch and ultimately retract those teeth, because we wanted to retract from a flared position to a normal position, we would put a labial bow on to control that. I showed a picture of an appliance with a little secondary screw. We would put a labial bow on that so that if the patient turned the screw too far, they wouldn't push the tooth further out than we wanted it to go. So I would say the default is, unless it's a retainer type appliance, we don't put them on unless there's a reason to. So twin blocks, as an example, tend to flare lower incisors. So a labial bow can be very helpful to stop that from happening.
Okay, well, that was the questions that I had here. So everybody, thank you so much for being here. Thank you very much, Bill. That was very informative. I learned a ton. And I hope to see everybody back for the next one with Dr. Lowry, and that's in August. So thank you again, and have a good evening, everyone.
Thanks,
Bye.
everyone. Thanks, Lee. Bye-bye.